Well, good afternoon, everyone. Thank you for being here. I'm Tom Banchoff. I'm our Vice President for Global Engagement here at Georgetown, and I'm delighted to welcome you and our global audience online to this, the first of our Global Futures Lectures with Dr. Yong Kim, President of the World Bank Group. Thank you so much for joining us. We really look forward to your presentation on lessons from Ebola toward a post-2015 strategy for pandemic response. In a moment, I'll introduce President DeGioia, who will introduce Dr. Kim. First, though, a few words about the Global Futures Initiative and our conversation this semester on the global future of development. Over 2 years, starting this month, we're inviting members of the Georgetown community to undertake innovative research and teaching around critical, emergent global issues, and to engage in structured dialogue with world leaders in the public sector, business, and civil society. We're beginning with development this semester, and next semester we'll turn to the future of governance, and then to security and the environment in subsequent semesters. Over the full 2 years within our community, we'll be supporting interdisciplinary research that addresses these critical issues, and we'll be pursuing curricular innovation around the issues in collaboration with our successful Designing the Futures of the University initiative. But of course, the initiative also has an outward-facing dimension, exemplified, I think, by our gathering here today. In addressing pressing global issues, we want to build on our strengths. We want to build out the model of an engaged global university in service to the world. Now, in this connection, Georgetown is certainly distinguished not only by academic excellence around global issues across our schools and departments. It's also true that because of where we are here in Washington, D.C., and because of who we are, a Catholic and Jesuit institution, we are in a position to do more, to convene structured conversations with world leaders like today's. Conversations that address not only practical questions of power, interest, and survival, but also ethical imperatives of justice, peace, and the global common good. In this critical year, as the world community is deliberating the post-2015 development agenda in the run-up to the UN General Assembly in September, there's really no more important topic than the global future of development. And we're very grateful to Dr. Kim and to his colleague, Senior Vice President and Chief Economist Kaushik Basu, for being willing to give not just one, but 4 lectures over the course of the semester on different dimensions of our topic. We're certainly grateful to all of you for being here, and to those of you joining us online via webcast. We have some 40 bloggers around the world across 5 continents, including 20 representatives from our Jesuit Higher Education Network, who will be following today's lecture and the whole series and joining an online conversation on the Global Futures website. So of course we're here in Washington, D.C., but we aspire to make this a truly global conversation. It's now my pleasure to introduce the President of Georgetown University, Dr. John J. DeGioia. Dr. DeGioia became our 48th president in 2001 after more than 2 decades of service to Georgetown in a range of leadership positions. Since 2001, under his stewardship, Georgetown has emerged as a global force in higher education and as an innovator in efforts to link up our core mission of teaching and research with service to the wider world. Examples include our campus in Doha, Qatar, which is celebrating its 10th anniversary this year, and our work with the World Economic Forum around the role of faith and values in global affairs. President DeGioia addresses broader issues in higher education as chair of the board of directors of the Forum for the Future of Higher Education, and as a member of the board of directors of the Association of Jesuit Colleges and Universities, among many other leadership positions. Ladies and gentlemen, please join me in welcoming President Jack DeGioia.
Well, thank you very much, Tom. Welcome, everyone. It's my pleasure to be with you this afternoon and to thank you all for being here for the inaugural lecture of the Global Futures Initiative. We gather today in Gaston Hall as we have throughout our history. For more than a century, this hall has served as one of the most important places for public discourse and discussion in Washington. Today we deepen that history as we come together to engage in conversation on the future of development. We've also come together today to inaugurate a new initiative, as Tom described, and I wish to thank the faculty leaders from across our schools, and especially to our Vice President for Global Engagement, Tom Banchoff, for shaping this effort. The Global Futures Initiative captures in a new way the vision that we have for our way of life here at Georgetown, a way of living that has characterized our community for 226 years. This way of life, our way of being, is a reflection of our international character, of our Catholic and Jesuit identity, and our roles and responsibilities as a university. Whether through the formation of our students as women and men for others, through the inquiry, scholarship, research of our faculty, and in the responsibility we have for promoting the common good, it is the ethos, the characteristic spirit of our university to seek the betterment of humankind. This spirit is at the core of the Global Futures Initiative, an initiative which brings together the resources of our tradition with the efforts of our community to discern and model what it means to be an engaged global university in service to the wider world. We can look to the words of the French Jesuit, philosopher and paleontologist Pierre Teilhard de Chardin, writing in the early and mid part of the 20th century to understand the work of our university in this new global context. His prophetic words are imprinted above the staircase in our Intercultural Center. And he writes, quote, "The age of nations is past. It remains for us now, if we do not wish to perish, to set aside the ancient prejudices and build the earth." The words of Father Deschardins point to the emergence of a new global community, of the forces of globalization, of new global institutions. What does it mean, in his words, to build the earth in this new context? And what does it mean for us here at Georgetown? We have come to understand that globalization is fundamentally about connecting. What we've identified is that for us to be able to achieve our promise and potential in the 21st century, we have to be connected in different parts of the world, connected with the most powerful ideas, with the most talented young women and men, with institutions that enable us to engage in work that we could never do alone. Globalization itself poses its own challenges, manifest in global warming, increasing inequality, worldwide economic and social stresses, limitations of our political and economic processes, expanding violence and the emergence of networks of terror around the planet, surveillance technologies and practices that alter hard-won privacies, gaping holes in healthcare systems that permit the development and spread of virulent diseases across borders. The Global Futures Initiative seeks to understand these challenges, to find new ways for us to connect and to learn from one another, and ultimately to live out our university's characteristic ethos to seek the betterment of humankind. There's perhaps no one better to inaugurate this initiative and to share his thoughts on the future of development than Dr. Yong Kim. The 12th president of the World Bank Group, Dr. Kim understands the perspective of the university, the impact of the NGO, and the leadership of global institutions. Since July 2012, he has led the World Bank Group, refocusing the organization's efforts to end extreme poverty and boost shared prosperity, and most recently has been a vocal leader in calling for a bolder and greater response to the Ebola crisis, an issue we have been exploring within our community since last summer. We'll hear more about these efforts and the future of pandemic response in his lecture today. A leading thinker on development, health, and human rights throughout his career, Dr. Kim has served as the president of Dartmouth College, as director of the HIV/AIDS Department of the World Health Organization, as a scholar at Harvard. In 2003, he was awarded a MacArthur Genius Fellowship. In 1987, he co-founded Partners in Health with Paul Farmer and others, an organization that today, more than a quarter century later, is a preeminent public health organization working in poor communities in 4 continents. We are honored by Dr. Kim's presence today in the first of 2 lectures that he will offer as part of this opening semester of the Global Futures Initiative. Ladies and gentlemen, it is my pleasure and privilege to introduce to you the president of the World Bank Group, Dr. Yong Kim.
Thank you. Thank you. Can you all hear me? Great. It's really great to be back, and I see a lot of students in the audience, which is great. I know you'll keep me honest. But you know, what I hope I can do today is just tell you a story. And it's a story that starts with the Ebola outbreak, but it takes you through a lot of my own history. And it's especially thrilling, actually, to be here in this hall, in this great university. Because at the core of the work that I've done for 25 years is a notion that comes from the Catholic Church. It's a notion that I had the great privilege of talking about with Pope Francis in Rome. I was with him, and he's, of course, born in Argentina. And I spent so much of my life, my adult life, in Latin America that I speak a little bit of Spanish. And so I was able to speak with him in Spanish about this notion of making a preferential option for the poor. It's language that comes from liberation theology, and it questions fundamentally what your life is about. Now, the organization Partners in Health had as its mission to make a preferential option for the poor in health. It wasn't a religious organization, and it wasn't a religious commitment, but instead it was a deep moral commitment to continue to ask in everything we do, what does this mean for the poorest? What does this mean for the people who don't have access to health care and education? And the really extraordinary thing is now at the World Bank, although not in exactly that form, we've made this our mission as well. Our aim is to end extreme poverty by 2030. And in order to get there, we're going to have to do things very differently than we have in the past, because every model of economic growth that we can conceive of, in even the most optimistic model of economic growth, we cannot get to below 3% extreme poverty. So somehow we have to change the relationship between economic growth and poverty. Somehow we have to ensure that economic growth has a bigger impact on lifting people out of poverty, on boosting the prosperity of the bottom 40%. Now, I think it's really important to tackle a problem as big as that, to tackle a goal as big as that, one problem at a time. So let's look at Ebola. Let's see. No, wrong. Okay, I don't think this is, there we go. I think you're going to have to do it for me. If someone can get me another little clicker, that would be great. Okay, hold on. There we go. Okay, now we're going. So this is the timeline of the Ebola outbreak. And the thing that surprises most people is it actually started in December of 2013. So it sort of perked along. There was a WHO recommendation in March. In April, MSF called the outbreak in Guinea unprecedented, and the reason is because it had gone beyond its geographical boundaries. Just about every epidemic in the past had been limited geographically, and then it continued. Now, in May 26, the Ebola outbreak was confirmed in Sierra Leone. We have thousands of cases now. And one thing that we have to remember is that every outbreak in these 3 countries started with a single case, and therefore we cannot stop until we get to 0 cases in all 3 countries. But I have to tell you, we are now doing a lot of thinking about, well, who knew what when, and I don't think that's helpful in terms of accusing anybody, because I'll take the first responsibility. I didn't really think very much about the World Bank role in this response until about here, mid-June. way into the response. And I began to be concerned because MSF began calling it an epidemic out of control in these 3 countries. And I began calling people and asking what's going on, are we on top of this? And there was a lot of confusion, and I wasn't getting information directly from the front lines, but with my experience in tackling other epidemics that I'll tell you about in just a bit, I became worried. And so one of the first things that anyone, that in terms of the first declarations of support, we announced $200 million on August 4th. And it really wasn't until 4 days later that WHO announced that this was a public health emergency, and also that, and then about a week later, the United States made a huge commitment to tackling Ebola. But look what happened. From January, we didn't get serious for almost 9 months. So there are a lot of sort of biopsies that we need to do of our system to find out why that happened. But it's important to know that this is a completely different epidemic than any of the previous Ebola epidemics. The previous Ebola epidemics, the largest number of cases was 425. We have 21,000 cases already. Fundamentally different than anything that we've seen before. It had never gone into cities before. It had never crossed national boundaries before. This was different than anything we had seen. And at one point, the estimations that we were making at the point when the number of cases was rising most rapidly really scared us. To the point of thinking, oh my goodness, is this completely out of control? Will we ever be able to get this under control? And there were very, very serious, skilled and experienced public health professionals who told me quietly that the world may never be the same again, that every fever that we ever treat again in any hospital will have to be Ebola unless proven otherwise. And so it looks better. Things are getting much, much better. The number of cases are going down. We're still trying to understand how it was that now that we were able to knock the number of cases down, if you believe the people who've done the most work in this area, it was probably because of behavior change among the populations. And so building the treatment centers, doing preventive work, safer burials, all this had an impact, but probably the most important part of it was behavior change. Now, why did we get there? And I'm sorry, this slide's not very good. I'll read this for you. But we never should have gotten to this place, because after a flu outbreak, H1N1 in 2009, there was a 2011 report of the review committee that said the world is ill prepared to respond to a severe influenza pandemic or to any similarly global, sustained, and threatening public health emergency. Margaret Chan, my good friend, the head of the World Health Organization, brought this to the World Health Assembly and argued for a $100 million emergency fund and increased capacity to respond to pandemics. And because the H1N1 epidemic was over, it was not in the newspapers, the world had forgotten about it. And that fund did not get built. Now, if you look at overall health expenditures in poor countries, so according to the WHO, from 2008 to 2012, the average annual expenditure for a year in the US was around $8,300. Sierra Leone, 178, Liberia, 78, and Guinea, 63. Now, we have promised, and we had promised many times, that we would build these health systems in the poorest countries. We even had plans. There were many public health professionals who put plans on the desks of funders, frankly now people like me, saying we need to fund these healthcare systems so that not only can they treat people for the diseases that afflict these countries most, in the case of these 3 countries, infectious diseases are still of higher prevalence than non-communicable diseases. But we had made promises for years, and we just didn't do it. And it's part of what I would call a very long history of low aspirations in providing health care for poor people. So, is it important? And how do we know that these kinds of investments are in fact important to do? Because it would be great if we could argue that not only is it the right thing to do morally, not only is it the right thing to do in terms of making a preferential option for the poor, but it's also economically important. Now, those of us, I'm not an economist, I'm an anthropologist and a physician. Those of us who've been working in poor communities for a long time had been arguing that it's the right thing to do morally, and maybe it would even be the right thing to do economically. But it was only recently that the most definitive and important paper was written. And this was a paper that was the chief author, the lead author was Larry Summers, former Secretary of the Treasury, former president of Harvard. He had authored the 1993 World Development Report called Investing in Health. Now, I'll talk to you a little bit more about that in just a bit. But in this paper in The Lancet, their analysis showed that between 2000 and 2011, 24% of growth in full income in developing countries resulted from improvements in health. 24%. So now it's not arguable anymore. And certain of the interventions like HIV treatment that extended the lives of people in Africa so dramatically, malaria treatment that had gotten so much better in which we were able to reduce mortality from malaria, those were some of the great interventions, but better health was 24% of the growth in full income. And so they argued that the economic benefits would exceed the costs of investing in healthcare by a factor of 9 in low-income countries and a factor of 20 in lower and middle-income countries. And Larry Summers, in a meeting at the World Bank, said, investing in health is the right thing to do, ethically and morally. But it's also the right thing to do if you can do basic arithmetic. The numbers are really clear now. It's a good thing to invest in health. Unfortunately, the World Bank didn't always take that position. In the 1993 World Development Report, they made statements about the importance of investing in health. But they also made other statements, including about user fees, which I'll talk about. Now, this book, Dying for Growth, was an edited volume on which I was one of the editors. And in that book, we argued essentially that the World Bank should be closed. And that the World Bank was so off target in what it was doing, especially around health, that it should be closed. I was actually part of a movement called 50 Years is Enough. About 20 years ago, on the 50th anniversary of the World Bank, I was here in Washington as part of a group. Some of us were out in the streets protesting and basically arguing that the World Bank should be closed. Now, as you know, we lost that argument, and I'm very happy that we did, and let me show you why. So back in the 1993 World Development Report, user fees. In other words, the recommendation was that health clinics should collect fees from even the poorest patients. And the reasoning was that it would reduce poverty, would actually lower actual costs for the poor because it would bring at least a little bit of revenue into the healthcare system, that it would increase the poor's access to medication, again, because of the revenue issue, and it would improve the quality of the services, again, because of revenue. And also there was the thinking that people value what they pay for. There's all kinds of mental models, and I'll tell you what I mean by that in just a bit. And in this book, Dying for Growth, now, by the way, let me tell you, when I was president of Dartmouth, and on a Monday I got a phone call from President Obama, actually from Tim Geithner, and Tim Geithner is a Dartmouth grad. So when he called me, I thought, because it was admissions season, I thought he was trying to tell me about a good candidate that he wanted to get into Dartmouth. But he asked me, would you be interested in being president of the World Bank Group? And so I said, well, you mean the World Bank? And he said, yeah. And then he said, well, why don't you come down and see President Obama? I said, well, how about tomorrow, he said. Because the nomination had to actually be made on a Friday, and the call was on a Monday. Now, when I went there, by the way, I just as an aside, I need to tell you this story. It's an object lesson for how you get a job, right? So I went in to see President Obama, and President Obama said to me, Jim, you're not a macroeconomist. And, the World Bank is all about economics. And so what do I tell other great leaders? And he mentioned, like former President Ernesto Zedillo from Mexico, who actually is a macroeconomist. He said, what do I tell them about why I should choose you as opposed to a macroeconomist? And so without hesitating, I said to President Obama, I said, President Obama, have you ever read your mother's PhD dissertation? He looked at me and he said, Well, yes, I have. And President Obama's mother was an anthropologist. So I said, well, then you'll remember that in her dissertation, she argued that while the whole world was saying that globalization would wipe out the Indonesian artisanal industry, she showed that metal workers who are creating art, that their business actually exploded. And so the difference between what I'll do and what a more macro-oriented person will do is I've been on the ground for 25 years, and I'll try to help you think about what the impact of these programs are on actual people on the ground. And he looked at me and he said, okay, I get that. Now later, we were together in a more relaxed moment, and he said to me, he said, Jim, you know, that was just about the best ploy to get a job I've ever seen. Now, so if you're looking for a job, read the mother's thesis of whoever is interviewing you. Anyway, so we argued against the World Bank position on user fees. We said that it was an effort to reduce healthcare expenditures, and with a lot of cheek, we said that it was an effort to maximize funds available to service loans to groups like the World Bank that should be shut anyway, right? And we also argued that user fees were not created, in fact, to improve people's health, and we didn't believe that it would create greater efficiency. Now, here's the great thing about the World Bank Group. I have never met a more dedicated group of people in terms of looking at the evidence and then speaking from the basis of the evidence, because they changed their minds. This is before I got to the World Bank. I'm sorry, again, it's a little bit, the contrast isn't good, but a World Bank Group report in 2013 said that raising the price of a good or service has two effects. It reduces demand and increases supply. In the case of user fees for health, it was thought that paying for a service also makes people use it more appropriately. In other words, you don't go to the doctor for minor ailments and value it more. See, now this is the mental model. You value it more if you pay for it. If they obtained it for free, the new empirical evidence shows that this reasoning is incorrect. And so I gave a speech at the World Health Assembly when I pointed out that for the poor, even tiny out-of-pocket payments will prevent them from going to seek care, and they will literally die because of the existence of even the smallest payment. So this is really what we want to see. We want to see in development a critical look at evidence, and then the ability to change your position as the evidence changes. Now, one of the things that we did this year, every year we write something called the World Development Report, and in it we tackle a major issue in the world of development. In years past, we've studied risk, we've studied the problem of job creation, we've studied gender, we've studied fragile and conflict-affected states. But in the 2015 World Development Report, we looked at a topic called mind, society, and behavior. And this was digging into the fascinating and quickly expanding work in the area of behavioral economics. And a lot of the people who've had the biggest impact, Daniel Kahneman is one of them, are in fact psychologists. Now, I became very interested in the new psychology. I mean, it's not the new psychology, it's the psychology that was new to me compared to my graduate school days. And I was fascinated by how experimental technique has improved so dramatically, and we're able to answer difficult questions about basic issues like how people think. And so economists typically assume that people make rational choices, that they carefully weigh their choices, they consider all readily available information, and they make decisions individually and on the basis of a clear rationality that is perhaps responding to specific incentives. But we've now found out that that is not in fact true, and that people much more frequently think automatically. They tend to rely they tend to think fast and rely on mental shortcuts, that they think socially. For example, people cooperate as long as others do the same, and they rely on social networks. And very importantly, they think with mental models. In other words, we don't necessarily invent new concepts, but use mental models drawn both from society and a shared history with others. And so there are lots of ways that these manifest. But one of the things that we're doing at the World Bank Group is we're taking this information and turning it back on ourselves and asking ourselves very basic questions like, do we at the World Bank Group have biases in the way we look at particular projects? And to do that, we actually did a study. And unfortunately, I don't have a slide and I don't have the specific data, but I'll tell you what it was. We used, we surveyed World Bank staff, and we used the exact same data and asked them to answer a question about which was more effective, A or B. And the first thing was about the impact of certain kinds of creams for skin problems. And the other example, Kaushik, was it conditional cash transfer program? Minimum wage increases and its impact on limiting poverty, okay? So in those two, World Bank staff, given the same data was used for each of the two examples. And so in other words, the answer to the question, there was a correct answer. The data would suggest that in order to achieve the goal that was stated in the question, either A or B was going to be the better answer. And so on the question around skin cream, the World Bank staff did very well. But on the question on minimum wage, the World Bank staff did much less well because people came in with preconceived notions about the importance of a minimum wage. So this is tough, and we're not saying that the World Bank Group is especially biased in the way that they think. What we're saying is that this happens even among groups of people who all their life have been thinking rationally and making choices, at least we all think, based on rational decision making. And so I am going to try to apply this analytic framework to the Ebola response and why we need to change in some fundamental ways our mental models if we're going to put together a response that's equal to the challenge. And in this case, it's pandemics. So mental models can be error-prone. You think unconsciously. They're self-reinforcing. They limit our ability to change. They constrain our ability to recognize new situations, and they're subject to bias, that we either confirm our prior understandings. And in this case, one of the mental models that I have been working to change for most of my adult life is low aspirations for the poor, especially in healthcare. So I'm going to just take you through two quick examples of my own work and how we confronted mental models that were so powerfully entrenched. We did make progress on them, but it was among the most difficult things I've ever done. So MDR-TB, multi-drug resistant TB, by definition, a strain of tuberculosis that's resistant to the two most important drugs, isoniazid and rifampicin. We started stumbling upon epidemics of multi-drug resistant TB in some poor communities. We found a few cases in Haiti, but then we discovered this outbreak in a squatter settlement in Lima, Peru, where I had gone to work with Father Jack Rusin, who was part of the Society of St. James, a missionary society made for diocesan priests. And so we found this epidemic, 50 patients in one small town, which is an outbreak, more or less. And we started saying, well, we've got to treat this. But back in those days, we had no data. We knew that it killed a lot of people because it's extremely difficult to treat. It requires 18 to 24 months of therapy, and often you have to give an injectable, an intramuscular injection 6 times a week for up to a year. Very difficult to treat. And because there is no market for new TB drugs, we've only had 2 new TB drugs in the last 30 or 40 years. So not only is it a terrible disease to have to treat, but it's also one in which poor people, mostly poor people, are affected. And because there is no first world market for MDR-TB, the drug companies have not been making drugs for the market, which is very different from HIV. And if with HIV, there's still a very large market in the developed world, so the new drugs keep coming out. But for TB, they don't come out. So we knew that it was a problem. Now, when we discovered this epidemic in Peru, we started saying, well, these are people who have drug-resistant tuberculosis. We saw family clusters. In other words, they were spreading it to their families. It was now spreading in prisons. And we'd heard of outbreaks in South Africa, we were really worried about the outbreaks in South Africa because drug-resistant TB epidemics were coming together with HIV epidemics. And HIV knocks out precisely that part of your immune system that prevents you from developing full-blown tuberculosis disease. But what we heard was this. The World Health Organization in 1996, in developing countries, people with multi-drug-resistant tuberculosis usually die because effective treatment is often impossible in poor countries. Now, the people who wrote that sentence had never in their lives tried to treat MDR-TB in poor countries. And they also said MDR-TB is too expensive to treat in poor countries. It detracts attention and resources from treating drug-susceptible disease. We asked them, what do you mean it's too expensive? And they said, well, the cost of treating one case is $250,000. Well, why is that? The drugs are expensive. They cost $30,000. And so we had a meeting in Cambridge when we asked, well, okay, so do you know if the drugs are on patent or off patent? Because if they're actually off patent, they would be expensive only because rich countries use them in small quantities. And if you made them in larger quantities in India or China, you could bring the price down. And when I asked the people who made this policy whether or not the drugs were generic or non-generic, they told me, we don't know. So they had declared a death sentence on this particular group of people without checking to see if you could lower the drug prices. So guess what? We got a whole bunch of people together. And now, the WHO came around quickly on this and became our very close allies. We lowered the price of drugs by about 90% because they were all generic drugs. It had all gone off patent at that time. And now we have almost 100,000 patients on treatment. The thing that changed the mental model, we think, is that even though they told us not to treat them. It was worse than just telling us not to treat them. The head of the tuberculosis program in Peru at the time, who's now a very good friend of mine, one of the most brilliant tuberculosis program managers in the world, was so afraid of raising the specter of drug-resistant tuberculosis that he told us that if we treated a single patient for multi-drug-resistant tuberculosis, he would have us kicked out of the country, right? He didn't say, well, we thank you for trying and for caring, but it's probably better not to do it. He threatened to kick us out of the country. So what did we do? Of course, we started treating the patients. And when we started showing as much as 80% cure rates higher than the best hospitals in the United States, when we started showing the higher cure rates, people began to come around. But it took years. It took years and years and years to change people's mental models because people just couldn't get it in their heads that it's possible to treat drug-resistant TB. And as I showed you before, now it's very widespread. Another problem that I've worked on, HIV. And the amazing thing is that the students who are undergraduates don't even remember a time when the threat of HIV was the scariest thing on earth. This is a graph that just shows you life expectancy drops in high prevalence countries. And this goes up to about 19, these are wrong numbers on the bottom, by the way, I'm sorry, we got the dates mixed up, but this here gets us about to the year 2000, all right? So at around the year 2000, we saw life expectancy drops in some of these countries that we frankly had never seen before. These were demographically some of the most frightening numbers that any of us had ever seen. And so there were millions of people, some 25 million people infected in Africa. We didn't know the exact number because people weren't getting tested, but our estimates were about 25 million people. And when we raised the notion that because, in 1996 was when we started having real drugs, the so-called highly active antiretroviral therapy that transformed HIV from a uniform death sentence to a manageable chronic disease in the rich world. That was 1996. But by 2000, still, people were very, very worried and couldn't get it in their heads that you could have this treatment and make it effective in Africa. And so the kinds of things that people said at that time, and I don't know that any of them would admit that they said this, but this was 2000, 2001, 2002, 6 years, as long as 6 years after this treatment was available, there were things like, this is one of my favorite ones. A high-ranking US government official said that many Africans don't know what Western time is. You have to take these AIDS drugs a certain number of hours each day, or they don't work. Many people in Africa have never seen a clock or a watch their entire lives. And if you say 1 o'clock in the afternoon, they don't know what you're talking about. They know morning, they know noon, they know evening, they know the darkness at night. Now, this person had visited Africa just before, and the African dignitaries who had been with him said that the only one who was late for every meeting was him. Right? But you can hardly believe it, right? This is what people were saying. And it wasn't just sort of people out of the loop. Everybody was saying it. Everybody was saying that it's impossible to treat HIV in Africa. Now, here's another one, and this is one of the most honest statements we've seen. It's so politically incorrect to say this, public health official says, but we may have to sit by and just see these millions of already infected people die. He said this, acknowledging that this was an option that would be considered unacceptable in the developed world. Very few public health professionals are willing to take on the AIDS activists by saying that, but a lot of them talk about this in private. Right now, and for me, I was going crazy because once again, the justification for not treating HIV was that it was too expensive. A full year of AIDS medicine at that time cost about $10,000. And they said, just do the math, 10,000 times 25 million people, not affordable. But I came in, and many of us came in and said, but wait a minute, these medicines are still on patent, but the research-based pharmaceutical industry makes almost no money in Africa. So they're not actually losing market share if they were able to do some creative things, give licenses over to companies in India, and reduce the price. So still, they would say, yeah, but you're taking attention away from prevention. There's no infrastructure to get this done. It's crazy. But then we started asking, what would it mean for us, even though we know there are medicines that can keep people alive indefinitely, what would it mean for our entire generation to say to those 25 million people, I'm sorry, but it's inconvenient for us to treat you, you're all dead. I'll tell you right now that if we did not start HIV treatment in Africa, I cannot conceive of how Africa would have had the growth rates it's had over the past 15 years. Back in those dark days of 2000, very few people knew their HIV status because they knew that getting tested would only subject them to stigma and they would not receive treatment. So just the opportunity of treatment, we thought at that time would change things. Now, how did we change people's mental models? It was really quite stunning. And one of the, there's I have to say, one of the great heroes of the HIV treatment revolution, and someone who's still remembered very fondly in most parts of Africa, is President Bush. Because he and people like Michael Gerson and Josh Bolton, Mark Dybel, who's now at the Global Fund, these folks made a very strong argument morally that we should try to treat the poor. And I don't know if any of you remember, but it was in January 2003 at the State of the Union address where President Bush made this historic announcement. And one of the things that we had done, Paul Farmer, my longtime colleague, took these photos to the White House to show them. Because this is what people with HIV used to look like. People with HIV in the United States used to look like this. This is Joseph June. He's from Haiti. And we found him. He came to the clinic. He was carried by his mother, who is holding his arm there, but you can't see her, and his relatives. And they said, we don't know if you can do anything for him. And we found that he was suffering from both tuberculosis and HIV. We treated the tuberculosis first and started him on HIV medicines. But in that first encounter with healthcare officials, the mother quietly pulled Paul over and said, what I'd really like is some help for money for his coffin. So, a few months later, this is what he looked like. We called this the Lazarus effect of HIV treatment. You guys never see this anymore. You never see this kind of transformation. But what I did in 2003, right around that time, I was working at the World Health Organization, and we put these before and after pictures in every document. And it was, these before and after pictures went all over Africa. Now, I have to say, unfortunately, that even in 2003, many of those people who were very cynical and negative about HIV treatment remained that way. But these pictures had a huge impact in Africa. And so in 2006, I went to the annual AIDS meetings in Toronto. And some of our team from Haiti was walking by a poster from Kenya, and they saw Joseph Jun's before and after picture. And they went up to the people and said, "Hey, that's Joseph Jun, he's from Haiti." I said, "No, he's not from Haiti, he's from Kenya." And they were saying, here's where he lived, and here's the treatment regimen he was on. And they said, no, he's from Haiti. And no, he's from Kenya. So then the Haitian said, "No, he's from Haiti, and actually we brought him to this conference." And so Joseph Jun went, met the Kenyans, they realized it was him, they took pictures with him, they were hugging. Something happened, and it happened first and foremost, I think, among Africans. And it wasn't just this picture, but it was this fundamental sense that this was not a question of cost effectiveness. This was not a question of whether it was doable, whether there was the infrastructure. For President Bush, he did not know at that time that, one, it could be done, and that, two, it would have such a huge impact on the economic prospects of Africa. I've been telling that whole team about the impact that they've had, but it was very courageous. The Secretary General Kofi Annan was also a huge supporter of HIV treatment, but this was in the face of a powerful, predominant mental model that said that these complicated things are just not possible in Africa. So where are we now? Well, 11.7 million people. There's a goal this year of 15 million people receiving HIV treatment. Back in 2003, when I was at the World Health Organization, we set a target. At the time, probably about 300,000 or 400,000 people were on HIV treatment. There's 25 million people, but 300,000 or 400,000 were on treatment, and most of those were in Brazil. And so what I did when I went to the World Health Organization is we said, look, you've got to just change the discussion. You've got to, once again, change the mental model. So instead of arguing about whether or not HIV treatment was possible, we set a target. And we started in 2003, September of 2003, and we set a target of going from 300,000 to 3 million people on HIV treatment by the end of 2005. It turned out that it was a goal that was not reachable, but it was reached 2 years later, in 2007. And I think that really what we did was we brought out another mental model, which was based on compassion and optimism and possibility, and now we continue to do HIV treatment. Now, look, we also know that one of the best ways, and we didn't know this when we were arguing for HIV treatment, but we now know that one of the best ways to prevent HIV transmission is to treat the infected partner. More effective than any vaccine we've ever seen. The return on investment is 240% of program costs. The value of eradicating Africa would be equal to its entire economic output. We know now that this is a good thing. But I want to give you a sense, and it's hard to do it, but I want to give you a sense of just how desperate we felt when we were sitting there thinking that the world is going to decide to let 25 million people die, and that the most powerful people, the most powerful governments all felt that that was the only possible choice. So what about Ebola? Well, in the past, Ebola has always been focused on containment. A very good friend of mine I admire tremendously, in the early stages of this epidemic, we were talking about Ebola. And I emphasized that in the epidemic that we were seeing with so many patients infected, with it moving across borders in cities, that we had to really also focus on high-quality treatment so we could raise the survival rates from Ebola. And he told me with complete honesty and openness, he said, "You know what, Jim, I have to be honest with you. I don't care if 100% of them die as long as we stop transmission." Right? Now, it might sound cruel, but it is true that stopping transmission, stopping it from moving to cities, stopping it from moving across borders is the most important thing. But what happened with that approach? I mean, the treatment that was offered to people who went into these early centers was really not much treatment at all. They didn't offer IV fluids. They didn't offer antiviral treatments. They didn't offer really anything but oral rehydration, just meaning drinking, and a bit of tender, loving care. So they really were places to go to die. And of course, the death rates were very high. Now, this is from the New Yorker. 19 people had died in Genwande since September. Early on, the villagers said, an ambulance had taken a number of victims to the nearest Ebola treatment unit in Monrovia. Not one of those people had been seen again, nor had health officials provided any update on their status. If treatment meant death, the residents reasoned they would rather die at home. So in this particular epidemic, it turned out that quality treatment did make it, or could have made a huge difference. Now, in the end, as I said to you before, probably the change in behavior is the most important thing. But here, we were, and this has turned into an argument. My colleagues at Partners in Health have been arguing very vociferously for more advanced treatment, whereas others have been saying, no, it's not necessary. But the argument has turned into one, I think, in my view, of competing mental models. Folks from the other camp were saying things like, well, you know, it's too difficult to do IV treatment because it's hard to insert needles while wearing 3 pairs of gloves and foggy goggles. True, but would you get away with that here in Georgetown? Of course not. And so one of the things that we have to now do is to think about, you know, the people who've responded to Ebola are heroes, and we don't want to suggest otherwise. But once again, what we see in this epidemic is that mental models have led us to this situation. The notion that despite the fact that the Institute of Medicine, the World Health Organization in 2011 said we are not prepared, we are woefully underprepared, we have to get prepared, for some reason it dropped off the radar screen of all of us, and we got to this situation. Now, the survival rate is so different for this epidemic. And it's not going to be, this is not the main focus of our pandemic facility, but I just want to point out, think about the United States. This is from the Ebola situation report, but just think about the United States. There have been 10 cases of Ebola, and 8 of them have survived. The only 2 that have died have been 2 Africans who came to care late. In one case, in Mr. Duncan's case, we made a mistake. We sent him home and didn't ask some critical questions, and we probably could have saved him as well. The other patient that died from Sierra Leone came in a state of, he'd been so advanced that it's hard to imagine that he would have survived. But we can reach 80, 90, maybe even 100% survival if we catch the cases early and provide intensive treatment. So for Ebola, one of the things that we now know, and we want to put in place, is treatment that's capable of turning it less into this fearful death sentence. If we can do that, along with putting these other pieces together, we think we can change the ballgame completely. Let me just go on to the plan, because we want to get to some questions. So, is there right now a risk that something much worse than Ebola could hit tomorrow and run through the world with a death toll that's unimaginable? Well, most people would say absolutely. The Spanish flu of 1918, there were 25 to 50 million deaths, 500 million infected worldwide, 25% of the US population got sick, 650,000 died. And it was mostly the young, the 20 to 30-year-olds who died at the highest rates. So we know that this is all possible. SARS, some of you may not remember, in 2003, the SARS epidemic had a huge impact. And most people will say that the reality of a pandemic is right with us. And if you ask the people who are most focused on risk, who every day think about the risks in the world, the insurance industry executives, they will say that the number one risk is of a pandemic, a new, highly infectious, fatal disease that spreads through human, animal, or plant populations worldwide. And what they have been saying to me in my meetings with them is that, you know, we actually hold a lot of the risk. In other words, they insure the people who, if their business is interrupted, these companies have to pay. So there is actually a huge fear and risk, but for some reason, the worlds of the insurance industry and the worlds of the pandemic response were not coming together. Oh, sorry. Now, we know that if we change the model, if we bring, for example, the rigor and discipline that the insurers have to have in understanding the exact nature of the risk, and working with us to assess whether our ability to respond is adequate. If we can do that, if we can put early warning systems in place, if we can find financing mechanisms that instead of waiting 9 months would disperse within hours, if we can have a greater incentive for vaccine and drugs to be made, and if we could have distribution networks that weren't just UN agencies, but FedEx and DHL, if we could do all that, that would be an adequate response. And that would be a response that would actually be equal to the risk that the insurance industry tells us exists every day. So this is a Canadian study. If you report early and respond early, this is the number of cases prevented. And not only do you prevent this number of cases, but what we know is that once an epidemic breaks out, aversion behavior stops economic activity, and the second part of the impact is just economic devastation, which the 3 countries, Sierra Leone, Guinea, and Liberia, are facing. So what do you need to do, and what do we need to put together? Well, the biggest problem, and I think the most promising potential solution, is to bring worlds together that work on the basis of very different mental models, that in the clash of these mental models might come up with something that we've never seen before, but that could be that could be impactful in a way that we never imagined. You need dedicated resources. Mobilizing funds after the thing starts, 9 months in our case, is not effective. You need to create a pool of resources that will quickly disperse. You need to get everybody who has a stake in preventing pandemics, which is literally everybody, involved. You need rapid and flexible resource deployment. You need something that we're calling the Pandemic Emergency Facility. Now, I'm not going to go into that. I can talk about this more if the economists in the room want to talk about it. But we have very specific mechanisms where we can raise money on capital markets and we can make it available quickly. The insurance industry, I was just in Davos, and we had for the first time a meeting of global health leaders and the reinsurance industry, the people who insure the insurance companies. This is like Swiss Re, Munich Re. And what they told us was, look, this is a huge risk for us. And we can create instruments, whether there be bonds, they're talking about pandemic bonds, we've never had a pandemic bond before, or insurance instruments. And the cost, if it's an insurance instrument, the cost of the premium would be dependent on the quality and adequacy of the response and preparedness. So the people in the room, we had kind of this, all of us had this sort of eureka moment. You mean that the private sector, because it actually does have a huge stake in whether or not we have an adequate response, might help us discipline and improve the response capacity of even the poorest countries. Now, this is very exciting to me, and again, I'll talk about this if you want, but there are so many ways for us to solve these problems, but only if we get people who are never in rooms together to sit together. Now, I had this other experience where in the middle of the epidemic, we had so much trouble trying to find ways of putting cell phone capacity in place, because the responders needed cell phone capacity. If we could have gotten cell phones in the hands of some of the health workers, it would have been very helpful. And we were talking to this person and that person, can you help us? And then at Davos, I was sitting at dinner with the CEO of Vodafone. And he said, we could have solved that problem for you. They have something called the Vodafone Foundation Instant Network. 4 boxes, you can put them on commercial airlines, deployed by trained personnel in less than 40 minutes. Handle 80 simultaneous calls, and provide cell and 2G data service, right? And I just sort of said, this is exactly the problem. That Vodafone had a solution that would have been enormously helpful, and there's no question in my mind that they would have helped us. But we just never had the conversations. Because we work as if these worlds, the UN system and the multilateral system and governments and the private sector, are living on different planets. From the perspective of pandemics, we are all living on the same planet, and we've got to make sure that all these conversations happen. So we now are working on it, and just today we had this long talk about how bonds and insurance policies could be used together, and we could bring the private sector in, who would give us a very different view on whether or not we were prepared. The World Health Organization has to play an absolutely critical role, and they have to be built up from where they were prior to the Ebola outbreak. But we have a chance to do something very, very special. Now, Let me end by saying one of the most important mental models that we have to change is the notion that we have time and that these things will not move quickly and that we don't have to move with a sense of urgency. We want to end poverty. We want to boost shared prosperity. And what we know is that growth of the economy alone will not be enough. We have to put the tools together to protect not only human beings, but the global economy from these potential shocks. Later in this series, I'll be talking to you about climate change, another one of the shocks. If you remember that list from the insurance industry, the second biggest concern is natural disasters, and a lot of them are due to extreme weather events. And so we believe that one of the things we have to do, in addition to spurring growth and making sure that growth has a bigger impact on poor people, we've got to make sure that we put in place these instruments that can protect the global economy and people from these shocks that we know will happen. We just don't know when they'll happen. Now, this is just the end. I want to just leave you with two examples that we're very excited about how you change people's mental models for the good. So in one program in Kenya, there was a study that we did where we gave one group of people an account book, a bank book, and told them to write down every dollar that they want to save for future healthcare expenses. And for another group, we actually gave them a lockbox, a physical lockbox that they could put money in for savings. And the group to which we gave the lockbox were 66 to 75% more able to respond effectively when they had health problems. So just the difference between a book and a lockbox was that big. In another study, which I think is one of the most extraordinary studies, there was a 2-year program provided to mothers of stunted children. Now, they also gave other things to the stunted children. They gave them better food access, but the one thing that seemed to have the most impact was in the group of people where a young person went and simply spoke to the mother about the importance of having a lot of interaction with their stunted child. And they went there every week, once a week, for 2 years. In that particular group, they tracked those students for 20 years. In that particular group, the children who were stunted and had no intervention, there was no intervention telling them to interact more with their children, they had about a 20 to 30% lower average income than the children who were not stunted. But in the group in which they got the intervention, their incomes were equal to the children who were not stunted. So a simple innovation, and it was an innovation that changed the mother's notion about what she should do for her child that was stunted. Now, all of this, and we just celebrated the Martin Luther King holiday, and people who work with me will say that everything makes me think about Martin Luther King, but it made me think about how important it is to have a sense of urgency about these matters. Could a huge pandemic happen tomorrow? Yes. On top of Ebola? Yes. Could extreme weather events happen in a way that just destroy communities and plunge people into poverty? Absolutely. And what do we need to feel as a community like Georgetown, as a group like the World Bank Group? What I have tried to do by giving us a target, 2030, end of extreme poverty, boost shared prosperity, by giving us measurable targets, I hope that what we have been able to do is change people's conception of time. And I think nobody understood this as well as Martin Luther King. In his book, Why We Can't Wait, he tells about a white moderate who wrote to him in jail. And the white moderate said to him, "All Christians know that the colored people will receive equal rights eventually. But it's possible you are in too great a religious hurry. It has taken Christianity almost 2,000 years to accomplish what it has. The lessons of Christ take time to come to earth." To which Martin Luther King responded, "Such an attitude stems from a tragic misconception of time and a strangely irrational notion that there's something in the flow of time that will inevitably cure all ills. Actually, time itself is neutral. It can be used destructively or constructively. More and more I feel that the people of ill will have used time to much more effectively than the people of goodwill. And he ends by saying, we will have to repent in this generation, not merely for the hateful words and actions of the bad people, but for the appalling silence of the good people. Look, I come here because you are all the good people. But let me tell you, the fact that we have 1 billion people still living on less than $1.25 a day in conditions so awful that it's probably unimaginable to most of you is a stain on our collective consciousness. And even things like putting together this nerdy pandemic emergency facility, but a facility that potentially can help literally millions, maybe hundreds of millions of people avoid dying from these diseases or being plunged into poverty. This is something that we can do, and it's something that we can do right now, and we hope that all of you will join us in what we hope will become a movement to end extreme poverty on this earth. You are the first generation in the history of the world that can end extreme poverty in your lifetimes. I hope and I expect that we will all work together in accomplishing just that. Thank you.
Thank you. Well, thank you for that inspiring and wide-ranging talk and for that prophetic warning at the end. We talk a lot about the future, but what you're telling us is that the future is now, and the good news is if we put our minds to it, we can address some of these problems effectively into the future. So we have a good 20, 25 minutes for a conversation. Dr. Kim has generously agreed to answer questions so that we can get through as many as possible. I'd ask each of the questioners who are lining up here in the center aisle to be very brief, maybe start by introducing yourself and then pose your question.
Great, people are coming up. I was going to call on people if you didn't come to the mic. Go ahead.
Thank you, Dr. Kim, for your interesting lecture. As you argued in your talk, the Ebola crisis is deeply connected with poverty, poor infrastructure, food and water and energy insecurity, and a race against time.
You also mentioned that spending resources and winning hard political battles to eradicate Ebola now will spare the rest of the world from the virus's spread, save lives, protect economies, and political security in the long term. Finally, you noted that the Ebola crisis is an issue of justice at heart because it is the poor and the least represented that suffer the most.
The fight against Ebola is similar to the fight against climate change in that they are both issues of justice and urgency, as you mentioned. At the World Economic Forum, you spoke in favor of fossil fuel divestment as a tool to pull support from coal, oil, and gas companies that continue to pollute our planet, harm frontline communities, and prevent the urgent transition to a clean energy economy. Unfortunately, a portion of Georgetown University is still investing our $1.3 billion endowment in fossil fuel companies. What do you think about a Jesuit university like Georgetown taking the lead on international issues of justice and human progress to a healthier planet for all people by divesting in 2015? Thank you.
So is that one question, three questions? Well, you know, first of all, I think Georgetown is and has been, especially under Jack DeJoy, a leader in the discourse on social justice and what universities can and should do for the poorest, for climate change and other issues. You know, the divestiture issue is a complicated one. And if you look at exactly what I said that we can make choices. We can make choices about what we do, including divestment. But I want to explain to you what we do at the World Bank Group, because there are really two issues that we have to keep in our minds at the same time, which makes my job especially complicated. So on the one hand, we are in the energy business, and it is almost impossible to lift people out of poverty if you don't have access to energy. You know, all of sub-Saharan Africa has access to about 80 gigawatts of installed capacity, right? Which is less than Belgium, less than Spain. So there's just not enough energy there, and there's no doubt that into the future, fossil fuels are going to be part of the mix in these countries. Now, we are doing everything we can to avoid coal, which is the dirtiest form of fuel, but we're still engaged in trying to find ways of getting energy to people. Now, there's a lot of technological advance, but the technological advance will be accelerated enormously if we can get a price on carbon. So what I'm trying to suggest is it's complicated. And on the one hand, the World Bank Group has led a process where we went from everyone doubting whether you could have a global price on carbon to one in which in September we had a statement. We sponsored a statement saying that we need carbon pricing, and it was signed by countries that represent 52% of global GDP and more than 1,000 companies. When I was at Davos just last week, and President DeJoy and I were both there, I sat next to the CEO of the third largest carbon emitting company in the world. And he said to me, we need carbon pricing. Right? Now, what is carbon pricing going to do? There is actually a price to putting carbon in the air. We're just not recording it. We're just not using it. And it was striking to me that at Davos this year, all the leading energy companies were in favor of carbon pricing. So I'm trying to come to a vision, and again, I'll talk about this the next time I'm here, in which everybody has access to energy, that we don't tell Africans, for example, well, you missed your opportunity. Because, the rich countries put all this carbon in the air, you're actually just going to have to wait until we can offer you cleaner forms of energy. That's unacceptable to them, and it's unacceptable to me. People need to have energy. If we can do it with cleaner forms of energy, we have to. We have to look at every single kind of cleaner energy, including, in my view, hydroelectric power. There are lots of great opportunities for hydroelectric power. And in Africa, for example, about 1% of the hydroelectric power capability is exploited, whereas in the developed world, 60% is exploited. So there's the Africans, the people from poor countries, this irony is not lost on them, right? You rich countries put all the carbon in the air, and then you're putting all these restrictions on us. You're pulling up the ladder behind you. So let me put it this way. These are complicated decisions. Often divestiture means that you're going to have to take a big haircut and lose some value of your investments. And that means less money to invest in students like you guys, right? So I think these are complicated decisions, but let me put it this way. I think that even the third largest carbon emitter in the world can have a positive impact on climate change. I think that the oil and gas companies can have a positive impact on climate change. I think it's a problem that's so huge and that's also juxtaposed against problems like the need for energy for poor people, that it's going to take everyone working together. If we can set a price on carbon, if we can remove fossil fuel subsidies, if we can do other things that we know are just no-brainers, climate smart agriculture, total no-brainer, cleaner, more livable cities, complete no-brainer, more financing for renewable energy, these are all no-brainers. If we can move forward in those areas and then have universities do what they can do at the time when they feel it's appropriate, I think we have a chance. But let me congratulate you guys on being very, very focused on climate change. Because the scenarios that we've put together, you may have seen some of our reports, to turn down the heat reports. The scenarios that we're looking at, Bangkok, Thailand could be underwater by 2030. Right? Some of these countries, Vanuatu, the Maldives, they're looking at just obliteration of their countries. Right? So this is very real, and there's no simple answer to any of this stuff. I am going to continue to fight as hard as I can to ensure that poor people in Africa have access to energy. But there are so many good things that we can do that will take us to the future that you guys deserve.
Thank you.
Let's take 2 questions, maybe. Please. Mm-hmm.
Hi, I'm Lauren. I'm a first-year student in the Global Human Development Master's Program. Thank you so much for talking. This has been wonderful. I was just wondering, you touched a bit on how the global community, the conversations we need to have and the responsibilities we need to take on to prevent another Ebola-like pandemic in the future. But now that it's happened, and even though the pandemic is controlled and beginning to wane, what conversations do you think we need to have, and what responsibilities should we take right now to help rebuild these countries and the economic fallout that is happening and bound to happen for the years to come?
It's a great question. You know, one of the things that we've tried to do is to very quickly go in and work on rebuilding even as we're responding to the epidemic. So, for example, IFC, our private sector group, just announced a recapitalization of banks in Guinea. In other words, you know, everything shut down, so the banks didn't even have any cash, and so we're investing in some of the banks. We're trying to get the rubber industry back up and running. We're trying to work with some of the mining companies to get ready to come back in. We have to think about it. It's $1.6 billion of loss for those three very small economies, and so we've got to get them back on track. But you raise another question, and it's implied in your question that we're at risk of forgetting. We're at risk of forgetting these three countries, and we're at risk of forgetting how scared we all were when we thought this thing could be completely out of control. And that's what happens every time. And so the promise I'm making to leaders in Africa and even to the private sector folks, right? Because actually it's the reinsurance industry that never forgets, right? They're the ones who, because they're holding the risk, literally holding the risk in their hands, they never forget. So the promise I'm making is that, you know, by this strange coincidence, an infectious disease doctor happens to be president of the World Bank Group, we are not going to let the world forget. And it's the same thing with climate change. Now, there seems to be more momentum around climate change, but what happens is that when there's an extreme weather event like Hurricane Sandy, all of a sudden everyone starts thinking about climate change, but then it goes away very quickly. So we want to be the organization that doesn't forget between the headlines. And in this case, the act of not forgetting is to bring the real legitimate stakes that the private sector has in preventing a pandemic, together with the people who are most committed to responding to pandemics, groups like the World Health Organization, and make sure that that conversation continues until we have a response adequate to the challenge. It's the same thing with climate change. And so you're absolutely right to ask about economic development. It's a huge issue. We have to both build back a much better healthcare system and ensure that that the economy is back on track. And we're doing everything we can to do that. Thanks.
Thank you.
Hello, Mr. President. Thank you for this beautiful presentation. I'm Furkan Pehlivan, a freshman student in School of Foreign Service. I would like to ask you a question that I would like you to answer as a physician and anthropologist instead of the president of World Bank. You talked about the relationship between the poverty and health expenses. Till now, most of the epidemics around the world start outside of the US or other developed countries. So developed countries was able to protect themselves through strict border control, as you said. But if an epidemic outbreak happens in one of the powerhouses of the world, such as US or China, which has huge populations, how the World Bank would act against these outbreaks? Isn't that the risk of outbreak underlines the importance of the free healthcare that should be provided by the governments? Because since the globalization in today's world is unstoppable, and these countries are highly globalized countries. And bottom line of the question, do you think US should have free healthcare?
Free healthcare. Well, you know, the United States is one of the countries in which the World Bank doesn't work. But you're a very tricky guy. You said don't answer this question as president of the World Bank, right? Look, what do I think about the healthcare system in the U.S.? I think that without question, the best physicians in the world, or many of the best physicians in the world, are here in the U.S. I trained with at the Brigham and Women's Hospital, one of the most astounding institutions I've ever been part of. Right? And we have fantastic healthcare, but we spend 17% of GDP on healthcare. Roughly double that of the next highest spending country. And so I think there are deep issues with the U.S. healthcare system. And one of the issues of the U.S. healthcare system is that some percentage, and experts who know this far better than I, have argued that 30 to 50% of all health expenditures in the United States are not only wasteful, but often harmful. And in other words, the way that the healthcare system is structured in the United States is such that we spend too much money for too little output. In other words, we should be much, much healthier for the money that we spend. So 17% of GDP. Singapore has much better health outcomes. Well, not much better, but they have better health outcomes overall. Infant mortality rate, other indicators are much, much better than the United States, and they spend 4% of GDP. Now, it's a small country, only a few million people, but they have organized their healthcare system in a way so they get just as good and sometimes better outcomes in the United States for 4% of GDP rather than 17%. So what I think we need in the United States is a complete overhaul. Not overhaul. We need to change the way we practice medicine in the United States. We need to do it in a way so that we're focused on health outcomes for the population as opposed to procedures. We're a very procedure-oriented medical system. And one of my jobs now, wherever I go, China right now, the leadership in China asked us to do a complete study of their own healthcare system, because they're at 5% of healthcare expenditures, and they'd like to get much better health outcomes. That's probably going to grow, but 5% of soon to be the largest economy in the world is a huge amount of money. And so we're now bringing to China all the best practices from all over the world. Jönköping, an area in Sweden, has a fantastic healthcare system. There are parts of the Singapore system that are great. There are parts of healthcare systems, there are parts of American healthcare systems that are great. We want to bring all those insights. And in China, we have a chance to work with them to actually restructure the entire healthcare system so that at 5% of GDP, they can have fantastic health outcomes. Now, it's so hard here in the United States because there are all these legacy systems, these systems that have been built up for a long time. And it's really hard to change the culture. I would argue that this is the hardest healthcare system in the world to change. But I think the Affordable Care Act has made a big difference. I lived for many years in Massachusetts, and when a version of the Affordable Care Act was enacted in Massachusetts, all the physicians told me that the outcomes got better, children had access to care. There was something very powerful about that particular change. We are not ideological about how you pay for it. We're not ideological about who provides health care. We have found some fantastic private sector healthcare services in the world. I mean, the Aravind Eye Institute in India is probably the best healthcare system on earth, right? And it's not government services. It's run by a group that are outside of government. The Air Eye Hospital in China is one of the best run eye hospitals I've ever seen, and they actually borrowed the approach from India, took it to China, and they're a private sector institution that not only pays 25% taxes, but is making money. So we're agnostic about how you do it, but we're going to help every country in the world that asks us to avoid the kind of mistakes that have happened in some high-income countries like the United States. So do I think everyone deserves health care? Absolutely, 100%. I'm not ideological about how you get there, but for the U.S., boy, the problem is you start with access, which President Obama did, but now you've got to take the next even harder steps, which is to really improve the quality and really lower the cost. It's going to be a tough road.
Thank you very much.
So we've only got just a few minutes left. Is it okay if we take the three questions together? Yeah. Would you like a note card?
Yeah. Great.
Okay. Please keep it brief, and remember to introduce yourself. Yeah.
Hi, I'm Tasmia. I'm a first-year Master of International Development Policy student at the McCourt School, and I'm also one of the Global Futures Fellows. So my question actually goes back to something you mentioned in your lecture, that in the past, the Ebola outbreaks in these countries have been contained. And so we've been relying on containment in many ways until the recent outbreaks. So across the developing world, we have similar outbreaks happening of the Nipah virus or neglected tropical diseases like dengue, which a lot of these countries are completely unprepared to deal with, and their health systems are definitely not ready for that. So in light of what we've experienced, how do you think we should go about addressing some of these challenges that haven't emerged as epidemics, but threaten to do so in the future? Thank you.
Hello, my name is Jen January Theory, and I'm a graduate student in the School of Foreign Service. Thank you very much for speaking with us today. My question pertains to your experience directly working in the field and with partners in health compared to your experience responding to the Ebola outbreak as the president of the World Bank. Did you at any time feel any frustrations or professional draws to go back to respond in the field, maybe take some time to do that, gain some experience, and then come back? And the second part of that question is, would you have any advice for officials who are dealing with messaging issues and responding to the outbreak, particularly because you do have this technical background and now are in a leadership position? Thank you very much.
Thank you.
Well, hi, Mr. President. I'm Alejandro from Mexico, and I'm now in a special program of leadership in the business school. And well, congratulations. And you talked with us about HIV and Ebola, but what can you tell us about the non-communicable disease, like hypertension and diabetes, and the economical impact in development countries like Mexico?
Thank you. Okay, so let me try to be as brief as possible. So the Nipah and other diseases, this pandemic facility, I think the great and exciting part of it is that we think we can develop different instruments and different response patterns for the different kinds of outbreaks. If we had had this fund, if we'd had all these conversations prior to December 2013, the cost of the Ebola outbreak would have been minimal. We would have been able to put it out immediately. We would have had teams ready to go. We would have had private sector companies, vaccine manufacturers, everybody lined up to respond. We would have put it out. That's the whole point. The diseases that are more limited, that move more slowly, this facility will allow us to put those out very quickly. The thing that's going to be the biggest challenge is if something like what happened in 1918. 25 million people dead in 25 weeks. That would mean the global economy would basically be shut down for that amount of time. Now, that kind of challenge is really going to test every single one of us. But what we know is that if we can respond to those things literally within days instead of over months, if we can respond quickly with our absolute maximum effective response, we can limit them. That's going to be the big challenge, and that's going to be, I think, the most difficult thing to achieve. But again, I would say it's completely possible. In terms of responding, so what's the difference between when I was at Partners in Health and when I'm president of the World Bank Group? So when I was at Partners in Health and we faced this epidemic of multi-drug resistant TB, we screamed and shouted and went to meetings, and everyone said we were crazy, and we begged for a little bit of money to treat a few patients, and we kept screaming and screaming. It took 4, 5, 6, 7 years before we were able to change any mental models. And it taught me a lot. It really taught me a lot. It, I think, helped me understand how difficult things can be. With Ebola, once I really understood the nature of it, I could pledge $200 million to fight it, right? So a little bit different. And so I did encourage Paul Farmer and others to get involved in the response, and they're very involved. And now they're doing great things in these countries. So Partners in Health worked with the Rwandan government, and the Rwandan government built a community health worker program that has 60,000 community health workers with labs labs and surgical services. And I dare say that if this happened in Rwanda, it would have been contained very quickly. So they're now working with the governments of Liberia, Sierra Leone, and eventually Guinea to build those kinds of systems. Now we don't fund it directly. If the governments take money from the World Bank and decide to fund those kinds of programs, they can do it. But that's quite different. I mean, to be, the motto of Dartmouth is a voice crying out in the wilderness. Well, we were way out in the wilderness, and not very many people listened to us. But now we have the opportunity to not only respond with money, but I now have the opportunity to say to the world that we at the World Bank will never forget the poor who face these epidemics, the global economy that faces this epidemic, and we think that we can really make a difference. And I think that's the key to the messaging. Because I'm an infectious disease physician, and that I understand now, working with the private sector as much as I have over the last 2.5 years, what the real risk is for them to bring their voices in and join it with the people who fight these epidemics every day, I think we have a chance to build something that is actually a new thing in the world. A pandemic facility that brings public and private together that actually protects people and the global economy. That's pretty exciting, and I know I could not have done that if I were at PIH. And non-communicable diseases, these are huge issues. A lot of them are related to lifestyle. But this is one of the issues we're taking on, for example, with China, that we think that the key to battling the non-communicable diseases is prevention and effective treatment before all the complications come from diabetes or hypertension or other of the non-communicable diseases. There has to be a real focus on building systems that are capable of tackling non-communicable diseases. Now, in Africa, it's not just communicable diseases anymore. They also have just as many non-communicable diseases. So the challenge, I think, going forward is, first, we've got to build these outbreak alert and response systems, and we're going to do that. But in the process, we also have to look at ways of building up the response overall. And why do we do that? Not because it's it's a moral conviction. It is that, but look at the data. Look at Larry Summers' paper, right? That investing in better health outcomes has such a big impact on income and on economic growth. There's such a big impact that we would be crazy not to take advantage of the opportunity and invest in improving health outcomes overall. Thanks very much for your great questions.
Well, thank you for being here. It's wonderful that you could launch this series with us. As you can see, there's already a lot of interest in your next talk on climate change. And on February 10th, the second lecture in the series will take place with Kaushik Basu on global economic development, what the trends portend. In the meantime, I invite you to join the conversation online. Thank you all for coming, and please join me again in thanking Dr. Kim.